Diabetes medications rack. The basic medications for type 1 patients obviously begin with insulin. Makes sense. It's also initial treatment for type 2 DM when BG's 300 or A1C's 10. Listen, this is humorous, though I'm partly still a true novice, and it's hard to remember brand generic. I know Apidra is glulisine, and Levemir is Dedimer, and I'll do one even betterer, that long-acting Lantus is insulin glargine. Isophane suspension, for short NPH, is intermediate acting, dosed once or twice daily. 2/3 before breakfast, 1/3 before supper, or right before bed if your blood sugar needs an upper. The other two basals are Dedimer and glargine, meant to cover blood glucose when someone is fasting. Bolus insulin is taken pre-meal because the BG it targets is postprandial. Insulin dosing calculations are weight-based summations. But what do you do for DM type 2? First and foremost, metformin. Yes, it's first line. Decrease hepatic glucose production. It's a biguanide. Improving sensitivity to insulin, helping the periphery to take it in. No hypoglycemia, and it's weight neutral. May help improve your lipid profile. Fasting blood glucose is the primary target. Can cause some GI side effects. Take with meals, cut in half, avoid alcohol. Think about the liver, B12 levels could fall. Sulfonylurea, SFU, helping beta cells do what they're supposed to do. Increasing insulin release because it's essential, but be careful of secondary failure potential. Hypoglycemia and weight gain are effects on the side from glipizide, glyburin, glimepiride. Target some postprandial and more FVG. See I and G6PD deficiency. Take precautions with the elderly and sometimes those with a sulfa allergy. Thiazolidinediones, rosiglitazone, and pio. PPAR gammas, what they activate, improving muscle and fat cell glucose uptake. They also decrease hepatic glucose output up to 6 to 12 weeks to see if it took. FVG a lot, postprandial a bit, black box warning for heart failure and bladder cancer risk. Edema, food retention. Don't forget to mention, not for active liver disease, annual LFTs, and to dispense rosiglitazone, you must be certified. Rosie's a heartbreaker. Cause an MI. Miglitinide. Non-SFU secretagogue. Repaglinide, nataglinide, targeting PPG for your BG log. Quick onset and short duration. Potential for drug-drug interactions with 3A4 and 2C9, and there are RDAs for repaglinide. TID, weight gain, hypoglycemia, for only a small decrease in A1C, must take with a meal or skip a dose. Maybe a better choice would be acarbose, or maybe it could be miglitol. Really, none of these are even second line at all. Not the alpha-glucosidase inhibitors. Carb digestion may delay, also delaying carbohydrate absorption, but like the previously described, the glitinides for only a small decrease in those A1Cs, and since they're taken with meals, also frequent dosing, weight neutral, and no risk of a blood sugar low, targeting post-meal level. Some GI side effects though, GI disease, hiatal hernia, those are contraindications. Renal and hepatic considerations. DPP4 inhibitors, sitagliptin, saxagliptin, allogliptin, and more. Inhibiting the enzymes which deactivate the hormones, endogenous incretins, you see, like GLP-1 and GIP. But what do those endogenous incretins do? Enhance insulin release that's dependent on glucose, and they suppress glucagon. Off-label use for DM type 1. PPG, low SE. Q-day, no weight gain. Beta cell preservation. Hypoglycemia minimization. Can take with food or without, but there are risks to take into account. Urticaria, pancreatitis. Angioedema, I'd have to be Midas. And all require RDAs except linagliptin. What about those other drugs that deal with incretins? Incretin mimetics, GLP-1s, glucose-dependent stimulation of insulin release, and just like before, keeps the glucagon from activating glucose stores. enhances satiety, delays emptying of the gastric variety, no risk of blood sugar low. Weight loss is a plus, helps preserve the beta cell, may help TG and HDL, but they have to be injected. Nausea and vomiting are expected. Pancreatitis reports decreased drug absorption, plus there's a warning in a box plaque of thyroid cancer seen in rats. I'll target postprandial. Byetta is okay with glargine. Victoza and Bidurian also target a bit of fasting. Byetta take before a meal, the others however you please. Exenatide is CI and GI and end-stage renal disease. Other agents approved for treatment of DM include bromocriptine, canagliflozin, and colesevelam. DHT2 agonist, SGLT1 inhibitor, bile acid sequestrant, respectively. Always exercise and diet, and that's all you'll get from me. Hopefully that worked.